Let me do that. Perfect. Thank you. So thank you for being with us as we are getting settled and welcoming everybody. Good morning, good afternoon. Thank you for joining us from wherever you are joining us from. We'd love to have you introduce yourselves in the chat if you want to say hello and tell us where you're joining us from, and your organization if you'd wish. That would be lovely. And I will go ahead and get started. And my name's Elena Boyer. I am Director of Implementation Research at the National Healthcare for the Homeless Council. I'm coming to you from Nashville, Tennessee, and my pronouns are she, her. And my colleague, Caitlin, will also be joining and sharing the work that she's been doing around diabetes work as well. Caitlin, do you want to say hi?
Sure. Hello, everybody. Thank you for joining us today. I'm Caitlin Sinonek. I'm a senior program manager focusing on medical respite work with the council. And I am excited to be here talking about this project specifically around meal planning for diabetes management and people experiencing homelessness. My pronouns are she, her, and I am located in St. Petersburg, Florida. So I think we will go ahead and jump in.
It sounds good. And just for recording purposes, thank you for joining us. We are a National Training and Technical Assistance Organization. So I just want to read off our disclaimer. So before we get started, this resource in this webinar is developed with support from the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award to the National Healthcare for the Homeless Council with 0% finance with non-government sources. The contents of those of the authors do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. So thank you for letting us get through that disclaimer briefly, but this is our agenda today. We're going to spend the first 15-20 minutes sharing with you two resources that Caitlin and I developed over the past 3 years with some of this work, and really listening to the voices of those on the ground and those with the lived experiences, as well as clinicians and providers, to really kind of think through how can we tailor some of these resources related to diabetes for folks that are experiencing homelessness. And then the second part is we have invited panelists who are community health workers. They've been in the field, they've worked in this area, and we have some focused questions that we'll be discussing with them. When we get to that part, we'll also explain how you guys can engage with the panelists as well, but the chat is welcome throughout this presentation. So thank you again for joining us. And Caitlin, I'll hand it back to you.
Great. So before we get started, just to sort of I think it's always helpful to do a little bit of level setting when we're talking about the population of folks experiencing homelessness, because that is a very large statement that covers a lot of individual experiences. And so when we're using the term people experiencing homelessness, we're using both the definitions that are put forward by the Housing and Urban Development, HUD, as most of us know it by, as well as HHS. And so when we're looking at the HUD definitions, with which folks working in COCs and continuums of care and housing services are really familiar with, we're talking about folks who might be staying in a variety of different settings, including shelters or missions, staying within their vehicles, those who might be staying outside or in abandoned buildings, folks who are living within encampments. This can also include people who are staying in single room occupancies, hotels, motels, something where there's not a lease involved and the payment is really required for day-to-day staying. And in some cases, also folks who are in transitional housing working towards permanent supportive housing. And also included in the definition of people experiencing homelessness by Health and Human Services, HHS, this also has a catchment of folks a little bit broader than the HUD definitions, and this may include folks who are exiting incarceration or treatment of some sort who don't have any plans or placement for permanent housing or shelter, which often affects many people exiting incarceration, substance use recovery programs, even skilled nursing facilities. HHS also includes folks who are living within supportive housing, because many of those individuals continue their support through healthcare for the homeless, permanent supportive housing programs, even after maintaining housing. And this also includes those who might be doubling up. So there's a roof over your head, but your tenancy is not secure in that particular environment. And then finally, somebody who is at risk or facing eviction, as well as other stable situations. So in our conversation today, when we're talking about diabetes management, we're talking about all of these different folks and all of these different experiences of being unsheltered, and so, or experiencing homelessness. And so some of that changes, right? What the living environment is changes a little bit about what the barriers, resources, and supports might be. So just thinking really broadly about that as we're having this conversation today.
Hey, thank you, Caitlin, for that grounding. And some of that might be really familiar with some folks on the call. I know we have a mixed group of folks that might be aware of these resources and the population, but I think it is really helpful because it definitely, as I was looking through tailoring the curriculum for diabetes self-management education that is provided through ADA, the American Diabetes Association. It really came out in our listening sessions how that looks different and how we can tailor different treatment plans to the setting in which people live. So thank you for that level setting, Caitlin. So the research that I wanted to talk to you about today is I'm going to go through a little bit of the methodology we use to kind of glean information again, from those with lived experience of homelessness and diabetes, as well as our providers within healthcare for the homeless healthcare settings, medical respite settings, as well as providers that are providing diabetes self-management, maybe in the street, so street medicine providers as well. And so those who might be less familiar with the curriculum or the domains within diabetes self-management education, I've listed them here, and some of them have different graphics, and I'll go through those. So one of the domains, medication management, can be very challenging. We know that there's different types of medication that can be taken to manage diabetes, different methodologies on how that gets delivered into the person. And so we went through a series of conversations about challenges and barriers with each one of these, but medication management and how to reconcile different medications is really tricky and important piece of self-management. We also talked about challenges and barriers to self-monitoring of glucose. So looking at glucometers and other types of ways to measure your A1Cs and challenges and barriers related to that, as well as facilitators. Of course, we looked at nutrition and food and access. And as you can imagine, it can be challenging in any of these settings. If you're in a shelter, you might be dependent on what's available in the cafeteria. If you're unsheltered, it might be what's available outside in the street where you have access to, or even a food pantry. So really kind of thinking through what that looks like for the individual that you might be treating. Physical activity, that also can be nuanced within our population. So we'll get through some of those things as well. But I have some of these check marks on here because these are some of the resources that are shared sometimes in education courses and classes that when you really kind of spend some time with them, don't necessarily always make sense for our population. So for example, finding places, just looking at the physical activity icon that I put there, just thinking about taking walks in the park, you have to think about safety or evenings or things like that, or criminalization and exposure. So thinking about maybe tailoring different times or places or spaces in which physical activity can be done is important. Coping and emotional domain is also something that needs to be considered and tailored because we have individuals and just experiencing homelessness in general is traumatic. So how do you prioritize your diabetes self-management within this scope of everything that an individual is experiencing? Of course, looking at risk reduction, things that you can do in preventative care might need to be tailored as well to our individuals. And then thinking about other co-occurring conditions that might be happening. We have a lot of folks that might be experiencing other types of chronic conditions in addition to their diabetes, but then also thinking about the secondary complications that come from diabetes itself and how do we manage those. So these are just the domains and areas in which diabetes self-management education and curriculums are built. Next slide. So the way that I've worked to glean information is I started with a literature review. I wanted to see what the literature was saying in the general population, what are challenges and barriers as it relates to diabetes self-management education, right? So the idea is giving education to individuals that have diabetes, be able to give them the skills and resources necessary they need to manage those diabetes outside of the four walls of the health center. And so we went through a series of publications that outlined what the general population might be experiencing in terms of barriers and facilitators. And also, is that at the individual level, is it the provider level, or is it structural or systemic? Those are important things to consider when we're looking at barriers and challenges. Then I conducted listening sessions. I used 4 different groups that I mentioned earlier. I wanted to get input from those with the lived expertise of homelessness and diabetes. Also looking at staff that are clinical and non-clinical within the healthcare setting and those providers and what they encounter when they are talking with patients. Looking at medical respite providers, and some of you might be familiar with medical respite programs, and we have some expertise on here, Caitlin, who can go into more detail if we have questions around medical respite, but really it's care for individuals who are discharged from hospitals but have not gone through full recovery, and really giving them a decent place to recover from hospital situations. So it's a really nice static location in which conversations around diabetes management might be a place where that can happen and get people involved. And then thinking about street medicine and what does that look like of individuals who might not be coming into a health center, but how do we manage that on the street and those who might be unsheltered and exposed to different elements. Then after we got the feedback, we were able to kind of map the similarities across the different groups and identify unique barriers to each group as well. Next slide. Just a quick overview. These are small numbers. This is not anything statistically significant, but just kind of getting an overview of what are providers seeing,
we're
the challenges related to diabetes care delivery when they are interacting with patients experiencing homelessness. And so essentially you can see that there is a lot of challenges across all of the domains of DSME, the diabetes self-management education. So that's from the provider's perspective, which I think is interesting, because on the next slide, if you go to the next slide, I asked the same question, but what I wanted to hear from the patients was, what do they see in terms of their challenges when it comes to managing their diabetes outside of the 4 walls of the clinic? And a lot of the patients that were responded to this question really don't have a lot of challenges in many of the areas, but physical activity and co-occurring conditions or complications are definitely ones that they have encountered as problems. But for the most part, their view is that it's somewhat. So we have this discrepancy too on what providers are seeing as challenges versus kind of what patients are being responding to as being challenges. So definitely a piece here we can dig into more and do some follow-up to figure out why there's a difference between those two perspectives. Next slide. So I'm not going to read through all of this, but I just wanted to share with you some of the shared barriers. And on the next slide, we'll talk about the unique ones. But I think what a lot of us probably already know around medication management and monitoring self-glucose are facilitators of obviously personalizing treatment plans. I don't think that's a new concept to people on this call. I don't think it's a new concept of tailoring treatment plans. So we all knew that when you do that, you probably have better results. You have better trust and hopefully likely improved outcomes for the patient. Hands-on practitioners being with patients, also just having occupational therapists involved in that conversation and having a multidisciplinary care team is really important. And of course, barriers that are very common is storage. We hear that a lot of your medications if they need refrigeration. We have a lot of challenges that's related to access to clean water if you need to take some of your medication with clean water. So and we can keep going, but nutrition, food, and access and physical activity. Again, the biggest piece here was less on the physical activity part and more focused on food access. We have food insecurity often coincides with persons experiencing homelessness. And that's either lack of access to food or limited to your food choice. So you might not be the one being able to create the meals and put the different ingredients together. You have a dependency on what is donated. And also this frustration of when it comes to diabetes, we have diets, we have plans. And so there's another loss of autonomy and self-agency on decisions of what you want to do on a daily basis. And again, this is a vulnerable population who is constantly having their self-agency and autonomy being scrutinized and most likely taken away from them. So this is just an added piece to that and something to be mindful of when providing extra care around diabetes self-management and related to food. Coping and emotional care. This is something that came up a lot was partnerships and making sure that we have peer supports, those who might have experienced, so not necessarily behavioral health providers, but someone that relates to them that has had the experience. And then again, having the behavioral health providers on there can also be a facilitator. Some challenges with as long as barriers is we know that staff and provider are really stretched thin. And while that is a systemic or structural issue just on workforce demands, it can leave a patient feeling unconnected, especially if it's their first time being diagnosed with diabetes. I think for sake of time, I will go ahead and go to the next one because we will provide these slides for you. And I'll also provide the more in-depth resource as well. But when we're looking at unique barriers, so this is the tailoring, I think, that comes that we need to consider more specifically when it comes to diabetes self-management. And I've labeled here which group was presenting it. And I think I cut off the legend, but LE is what we heard from the group of the lived experience. The HCH acronym are what we heard from our group of health center staff, either clinical or non-clinical. Medical MR is medical respite. So that's what we've heard specifically and uniquely from that group of providers. And SM is the other acronym on here, which is what we heard specifically from the street medicine providers. All of these listening sessions were held independently. So one of the things I wanted to point out is what we heard from individuals with the lived experience of diabetes and homelessness is the anxiety of looking at the numbers. We are definitely a number-driven society, and that tells us if we're doing well with our management of disease and not. And so there's a lot of anxiety when you have to check your glucose on a regular schedule, whether it's every morning or 2 or 3 times a day, whatever that schedule is. When you're experiencing homelessness and all the other things that are going on and now not meeting another expectation of where you're supposed to be, can be really anxiety inducing and cause emotional stress of maybe this is just something else that I'm just not meeting. So I think it's an important piece of the conversation that is important to also have peer supports there as well as behavioral health staff as well. One thing that I heard was interesting from our providers that are at health centers was oftentimes we know that diabetes medications can be stolen or lost when individuals don't have a place to store them. Something that actually might be helpful and is helping that patient fill out any forms in order to replace stolen medications or any insurance forms if your patients happen to have insurance. I know that's not a commonality among our folks as well, but being that support of how do we get this back going again? How do we get you what you need? nutrition and food. I think we heard that it would be really great if we could have nutritionists and dietitians even go on field trips with individuals to the food pantry and grocery stores. And I don't know if anybody's like me, but reading labels are difficult. I know we're probably trying to make them better, and I know there's a whole movement to make them easier to read, but really just being that person that goes alongside them to a food pantry or grocery store saying, this is what, you know, is good, that fits within your diet, that you can do. Also from the lived experience group, we did hear that cultural diet habits do matter, even if they're experiencing homelessness, and kind of thinking about, okay, well, if this is, you know, within your cultural diet, what can we do within that? So again, tailoring it also to the individual is helpful. Physical activity, also realizing that our individuals might be on their feet all day. Their feet might actually be in pain for multiple reasons, maybe diabetes related, sores on their feet. So really kind of thinking about different ways to be creative and innovative with their physical activity. Coping, thinking about mental and spiritual therapy, we heard from individuals' lived experience. And I think having consistent mobile routes, we heard from the street medicine, is also very helpful. So there's that dependency there. Then I think lastly, just touching on risk reduction and co-occurring conditions or complications, really just what we heard from that came up a lot that I want to highlight from the lived experience group is the feeling of shame or disappointment that they're letting their health team down, which again goes back up to related of like, I don't want to look at my numbers. I don't want to test my glucose because that's just one more thing that I'm not meeting. And so I think that's going to be a critical piece as we go forward. And so thinking about those multidisciplinary care teams with your behavioral health folks. And I have gone on for far too long, so I'm going to go ahead and hand it over to Caitlin.
Great. Thanks, Elena. I think that's really helpful, though, to highlight, especially those differences, you know, between the perspectives in diabetes management too, and can really, I think, will be something for us to think about as we go into our panel discussion. So I worked on a project similar to Elena over the past couple of years to develop a resource that is, the final title is the Meal Planning Guide and Cookbook for people with diabetes who are experiencing homelessness. And so this was a project that really hones in on the nutrition piece that, that Elena just chatted about in terms of diabetes self-management. So in terms, similar to Elena, I had a fairly similar process. We held listening sessions with providers, people with lived experience, and providers from all different roles. So we had registered dietitians, a few medical providers, a lot of community health workers that participated in these listening sessions to really talk about the barriers to care and what resources were needed or what resources might help them in their day-to-day work in supporting folks with diabetes. After that, so I worked on this resource with Darlene Jenkins, who's a registered dietitian. And so we did an environmental scan. Sorry, I don't know why this animation is funny. Looking at what was available currently in terms of recipes and meal planning resources, specifically for our population of people who are unstably housed. And then we worked to develop our resource based on both the feedback that we got from the listening sessions, what we found that was in existence, and just some, you know, emerging and best practices around diabetes management. And so we are in the publication phase. I'll talk a little bit about that later on, so that we have a resource that will hopefully be utilized by you all as you are doing your work once we publish. So again, we started with the listening session piece. These were all of the different folks that attended these listening sessions that we had. And really, they focused on what were the barriers for managing diabetes, what were the existing resources that people were currently using, and then what would really be beneficial, right? So as Elena talked about, a lot of the diabetes self-management publications, resources, guidance that's out there is more focused on people who are housed. It often doesn't focus on the population that we're working with. And even for those folks who are housed, really focused on people who have resources in a number of different ways. And so that was a lot of the gaps that what were brought up, and our listening sessions talked about what would be helpful that would be more targeted to the people that we are working with. So this is a list of the barriers that were identified, which for any of you doing direct service is probably not going to be super surprising that this is what came up. Specifically, that there's a lot of barriers for meal preparation. and following dietary recommendations for people with diabetes and who are experiencing homelessness. Again, as Elena said, these will get sent out, but things were around affordability, that people don't have full access to a kitchen. They might have access to a microwave. They might not have access to a kitchen at all. Folks who are housed living in a food desert, transportation to get foods, and that recipes don't reflect the culture of the client, which is one of those things that Elena just brought up as well, that's really important for people to be able to maintain that. Similarly, somebody might be learning how to cook or might be learning how to cook recommended foods for the first time, and then relying on what the food resources are. And so people don't have a lot of choice and selection if they're eating at meal programs, if they're receiving food from pantries or through donations, they don't necessarily have a lot of choice in what they're getting, and that can make it really hard to follow recommendations. Similarly, a lot of resources are not developed with literacy and health literacy in mind, in addition to some of just the individual barriers that folks have around motivation, trying to make family-wide changes versus individual changes, having time to prepare foods. So a lot of different barriers, both structural, I think, and then individual, that have to get navigated, which is why it can be really challenging for folks to make these transitions. So based on that, we had the ability to develop really what resulted in, it's going to be 2 resources, but they're partner resources together. So the first one is a meal planning guide. And what's included in this guide is strategies for meal planning. And the intended audience of the guide is really folks, providers who are working with people experiencing homelessness and diabetes, to help you develop some tools and resources and think about, how do we meal plan when somebody is unhoused or has unreliable food resources, considerations for respecting culture and food preferences, and then strategies for meal preparation and adapting recipes. So although we have a cookbook that accompanies this cookbook has 25 recipes, which is great, but there's tons of recipes and tons of things that people like to cook that might not be here. And often people who are working directly with folks are trying to adapt it, right, in a number of ways to respond to what people have available. And so we have some suggestions around adapting recipes, around different equipment to think about, that you can use different foods, different ingredients, so that people really know what they can substitute and still get something that they like to eat that maybe meets what resources and guidelines they need to follow. We've included examples and printable resources that go along with each section. So in the appendices, there's a sample meal preparation sort of planner, a sample grocery list that folks can just print out and use directly with the folks they're working with, a couple of quick guides around using a microwave, different resources that way that can be printed and used with your clients directly, that they can take with them as they leave as needed. These resources are intended to be printed and just used. And the final resource, this is going to be published on the National Healthcare for the Homeless Council website. All of the handouts will be available in Spanish, and the cookbook will also be available in Spanish in addition to English. So just a few things that we kind of came up with, again, based on the listening sessions that will be included in there, is strategies to support meal planning, considering that folks maybe be doing daily meal planning, right? That they're planning their meals and what they're eating based on what's available that day, versus other folks maybe who are housed and want to be thinking more ahead weekly or monthly. So strategies around that to be responsive to what people are navigating. Helping providers determine what's going to work best for the client, different examples of what that might look like, and then the sample forms that go along with that. Similarly, we have some guidance around meal preparation and using different recipes, where folks can find different types of ingredients, how to adapt recipes so that they still turn out well for folks if they're subbing ingredients, or they don't have a certain type of pot or pan available, and maybe I have a microwave. Some key considerations for being able to modify recipes, different ways to use different types of equipment and ingredient substitution. So there's a nice appendix at the end that has a ton of common ingredients and all of the different substitutions that you can use in a recipe and how much that substitution would be. So really that way, whatever people have on hand, they're able to use, and they're not buying 4 bottles of vinegar, don't feel like they can't make something because they can't afford to buy that. And then finally, in the meal planning guide, we have applying cultural humility concepts when you're supporting somebody with meal planning. Additional recommended resources if you want to do a deeper dive, reading some places that have some really good recipe options for folks, especially with more limited budgets or maybe who are within families. And then finally, another resource that's in there is a 24-hour diet recall and meal planning assessment form. Again, that can be used by providers with the person they're working with to really get a picture of what is happening in the person's life and where do we need to maybe develop some strategies or changes. And so then to go along with the guide, we also have a cookbook. As I mentioned, it has 25 or 20 total recipes. Sorry, my math is incorrect. There's 5 different recipes that require different types of kitchen equipment. So there's 5 recipes in which the person needs to have access to a stovetop or an oven. There's 5 recipes that require a microwave, 5 recipes that use a crock pot or a slow cooker, and then 5 recipes that don't require any cooking at all, that can be made and prepared. We intended the no-cook recipes to be something that folks that really use a minimal amount of equipment. So even somebody who might be staying outside or in an encampment, if they end up with some food items, might be able to prepare the food themselves just with really, really minimal resources. So that was the intention of those particular recipes, because we do know that sometimes that happens with folks. Every recipe that's included contains a list of ingredients, the equipment needed. So does it need a bowl? Does it need a spatula? Does it need a microwave? That is known before the person, while they're reviewing the recipe, so you can identify if that's something that that person can do in their living environment. The serving size, and then alternative ingredients specific to that recipe. So the full guide has a whole big list of alternative ingredients, but each recipe then for the ingredients in that recipe, that's included with it. All of the recipes are written at a 6th grade reading level. And they have been adapted and simplified often from existing recipes so that anybody that maybe has decreased cognition, challenges with executive functioning, difficulty paying attention, they should be able to read and follow the steps more easily than often how many recipes are written. We also included recipes that are applicable to those with little or no cooking experience. So trying to be explicit about not using necessarily words that people who are unfamiliar with cooking might not know, or trying to describe what's happening so that people are aware of what they're trying to do when they're following the recipe. So with that all being said, I'm really thrilled that we have our panelists here. So I'll ask them to come off camera for us. We have Lillian Amaya, Sarah Bird, and Rodney Dawkins. They will all have a chance to introduce themselves here in a moment. While we're having the panel discussion, as Elena mentioned, we have some selected questions that we're going to ask them to share their thoughts and experiences about. During that time, if you have additional questions, please throw those into the chat. Once we've had our panelists have an opportunity to share, we'll open it up for large group discussion, and we'll start pulling some of those questions from the chat. So if you have a good idea, a good question, please put that in the chat, both for our panelists and for Elena and myself about the resources that we've worked on. So I'm going to now turn it over to Elena, who's going to facilitate our discussion.
Thank you so much, Caitlin, and thank you all for joining us. I think at this time we'd like to introduce our panelists, and so thank you for coming off camera. And so while we're pinning you guys up so people can see you, I'll ask Lillian, you're the first one I see. Would you like to come off and introduce yourself and tell us where you're coming from and your role at your organization?
Sure. Thank you, Elena, and thank you, Caitlin. My name is Lillian Amaya. I'm coordinator of community health at Healthcare for the Homeless in Baltimore City, Maryland. I've been with the agency for the last 5 years. I started as a lead community health worker. Prior to that, I worked in shelters, serving women and children, victims of domestic violence. I've worked for residential programs serving people with severe mental illness. So I've been around for a while. Thank you.
Well, I'm glad you're able to join us today and look forward to hearing, I'm sure, all of the great information you'll have to share. Rodney Dawkins, would you like to come off mute and introduce yourself and your role and where you're coming to us from? You're muted still.
I'm sorry, Rodney Dawkins, he's a pronoun, Skokie, Illinois, Heartland Alliance Health. I'm on the Consumer Advisory Board, and I'm also on the steering committee, regional rep 5 and 7. And thank you for allowing me to be a part of something great.
Love to have you join us, Rodney. You know, we love hearing your input. It's great. Sarah Bird, would you like to
Hi,
comment?
everyone. Oh, thank you, Elena. Sorry. My name is Sarah Birdie. I work for a health equity zone in Rhode Island. So health equity zones are place-based initiatives that are community-driven and resident-led, working to address barriers to health caused by social determinants of health. A little background about me. When I was earning my master's in 2021 in health education and health promotion, I started with the East Providence Health Equity Zone as a community outreach specialist, connecting people to different services. And I spent the majority of my time at Rhode Island College doing research on addressing food insecurity and designing program initiatives to address both food access at a community and a systems level. I've since earned my community health worker certificate as well as my health education specialist certification, which has really led to where I'm at right now. So I have in my position as Road to Equity Coordinator. Basically, it's a grant coordinator. The title is very vague, very specific to Rhode Island itself. But I've been working to develop different health education programming and working closely with our CHWs in our food pantry through our backbone agency at East Bay Community Action Program. And we're hoping to continue this work as this grant comes to an end at the end of this month.
Well, that's exciting. Thank you so much. And I want to apologize because I think I pronounced your last name wrong. It's Birdie. So sorry about that.
Oh, you're fine. Everyone pronounces it Bird. So.
Well, I think we have a wonderful panel with us today. And so we're going to get started with our first question. And so I'm going to pose this one to Rodney. Would you maybe begin us off with talking about some of the barriers that you might experience or you've heard others experience in terms of managing their diabetes while living under housing unstable circumstances?
Well, so the first thing is when you're unhoused, even though you have a link card, to eat healthy or to eat vegan or lactose free costs more than anything now. That's the first thing. So when you're unhoused, when you go to these soup kitchens, even to some of these events, everything that they have has sugar. You should see the amount of sugar that individuals are putting in their coffee. The staff has to keep filling up the sugar like constantly. Their donuts, I mean, everything has sugar. So one of the things that we need to do, we need to have that nutrition class, which is a part of diabetes management. Eating healthy, cooking with the right spices, watching your carbs, that saturated fat, fructose corn syrup, and all these processed foods from Dollar Tree, because that's another one that will definitely cause your A1C to rise. Drinking lots of water, eating lots of vegetables, trying to cut back on so much of that McDonald's, especially McDonald's, because that McDonald's food will definitely tear you up. And then there's another key component is working with specialists. I mean, so you can go to like UIC and they have nutritionists. We had a nutritionist at Healthcare for the Homeless Heartland, but she went to the University of Chicago and she was really great. She used to come down in the lobby and she would have different recipes like the smoothies and different things like that, where it was very, very healthy. And the participants enjoyed that. So eating healthy, not only is it good to manage your diabetes, but losing weight, obesity, sleep apnea, all that falls in line with that diabetes and being obese. You have to eat healthy, but sometimes it's hard when you're unhoused because you're trying to meet a basic need that no one should be hungry in America. Yeah. So that's what I saw. And so trying to eat healthy is hard when you're unhoused because the meal starts at this time, and you gotta wait for your next meal load at that time, and then you gotta try to get in the shelter to get that meal. So hey.
Thank
Yeah.
you, Rodney, so much. I mean, I think it's really important, you know, when you're mentioning, we're just trying to get our basic needs met and, you know,
basic
you have
needs.
access. So thank you for sharing that perspective. I think it's so important in terms of how we deliver our education and being in person. I really like the idea of someone being in the lobby. So I think I'll reach over to Lillian. Can you talk about any of the biggest barriers around nutrition or following guidelines with diet that you've encountered with any of the patients?
Sure, thank you. Just as Mr. Rodney shared, it's difficult to try and eat healthier or foods with less sugar when you're depending on whatever's available to you, or what the shelter that you're staying at is serving. And there are some shelters in Baltimore where they will try and manage a better diet or meal for someone if they have a medical provider letter stating that it's recommended. But even if you think about that, you have to figure out how to get to your doctor and schedule an appointment and get there. So there's all these barriers to just trying to eat healthier and access that, especially when you have competing priorities. It's much easier to grab what you can to eat in order to get whatever else you need to get done, whether it's applying for food stamps or looking for a job. So these are all things that kind of take priority over the diabetes. I have a lot of clients who have the diagnosis of diabetes, but they don't feel sick. They don't feel like it's an issue because they might be on a medication, or they just don't have any issues with it yet. So that's the hard part, is when folks don't really feel the complications that diabetes could cause right away, and then maybe might start taking care of themselves later on when it's more serious. We have a lot of clients who they're at their general normal, I guess, state. Their blood sugar is really, really high. And that's just something that the nurses here see regularly. So it's a big problem. And I mean, I think it's hard to educate around diabetes, especially for community health workers. I know that in my family likes to eat a lot of sweet bread, pan dulce. Latinos, we like coffee and sweet cakes. So it's an issue all around, and the educating and informing people of the importance and relevance is tough to do.
Yeah, and Lillian, you brought up really, really great important points, and actually makes me think back to the slide I was showing around the differences between the provider responses and the patient responses, because it might have something to do with the fact that they don't feel sick at that moment, so they don't see those different domains as being a challenge. So thank you for giving me insight a little bit into that. But you also, you hit on the cultural aspect, right, of what the foods are in the family. And one of the things that I think is a great transition into maybe Sarah, Birdie, if you'd like to answer this question, but you talked about the access to benefits and kind of what does that look like, the social determinants of getting SNAP benefits. And if you don't have something specifically like that, please share with us kind of some of the challenges that you've encountered or barriers that patients have around food insecurity or physical activity.
Yes. So we definitely just like access and overall affordability to food is a huge barrier. We have one of the highest aging populations in Rhode Island. So mobility also plays a huge factor into that. And with SNAP benefits where they're currently at, they have decreased since COVID funds have been taken away, I guess, for lack of a better word. So we've seen an increase in the number of families and individuals coming to food pantries. But another thing that we've seen just in our community is like access to a kitchen is a huge barrier for individuals with diabetes that we're working with. A lot of them don't have access to a stove or oven, and they have, maybe if they're staying in a hotel, a tiny fridge, but no freezer really. So that's been a huge barrier. But also thinking about like the knowledge and ways to cook your food. We have a very large like Portuguese population. So thinking of that when we're working with clients or working with individuals, of how can we include like types of foods that they're eating, but creating ways for them to make them in the limited spaces that they have. And then lastly, like thinking about nutrition. So, you know, Instacart and different food delivery services, are those delivery fees are not covered by SNAP. So that's a huge barrier. And specifically in the city that I work in, we have an area that's considered low income, low food access, and the bus routes themselves are so much more spread out than the rest of the city. So access to just even the grocery store that is maybe a mile away, but on the bus it's going to take an hour. That's a huge barrier, because why would you waste 60 minutes going to a grocery store when you could go to the convenience store down the street and get something to eat? So that's something that we've definitely found. And I think transportation across the board just plays a huge factor in barriers to physical activity as well. And looking at mobility, you know, if you can't leave your apartment, you're not going to go on a walk. We have a lot of homebound seniors, and they've struggled with isolation and all of that during COVID, and it's continued. So finding ways to connect with them with both like nutrition education, but also ways that they can kind of stay active in an easy way that's not going to injure them, has been definitely difficult.
Thank you. Thank you for all of that. I think it's really important, all of the aspects that you all talked about that needs to be considered when delivering care and education. I'll put one more barrier question out there, and then we'll hopefully go more to the positive and facilitators. We've seen things that work, but this one's around medication management. So I want to, whoever feels comfortable coming off and talking about it, I won't definitely kind of target somebody, but tell me about some of the barriers around medication management. Yep, Rodney, go for it.
So I think for the people that's unhoused, so I don't take insulin, and I know people who are still dealing with that. That's really a barrier. But another barrier is, do you know how much it costs in the state of Illinois for individuals if they're in a situation where they don't have Medicaid or Part A, Part C, Part B? No American citizen, if they're unhoused, should have to pay out of pocket. The 1A system, that means that the entity picks up the coverage, because it is a ridiculous. I think I saw that somewhere. I think it was one of the Congress people here that they're pushing to lower insulin. Look it up. It is a ridiculous. The next thing is that you have to fast. I learned this from my brother. Before you do your so that means you do your blood sugars first, then you eat. Because when I was in the hospital, they did that a lot. And then also they want you to walk around, move around, dance. Well, I like to dance and stuff like that, because obesity and diabetes go together. Cholesterol, all that's related. So you have to participate in your care for the people that's unhoused. Yet the people that take insulin, I'm gonna fight for that. You get these people off the street, because they need that. They could lose their life. They could lose. It's ridiculous. Because I'm about to go off on this call.
Well, that's what it's for. And Rodney, that's the truth. You speak power to your experience. And, we did hear that in our focus, in our listening sessions as well, just not only just the cost and everything that's related to it, but just kind of keeping track of everything that you have to take and when you have to take it on daily.
Right. Exactly.
Regimen.
Right. You have to manage that. You got to keep it cold. You have to take it on time. And this is another one. Using the bathroom, because I know that was a big one for me. And I asked the doctor, can you please give me something to identify that I'm diabetic, so we won't get harassed by the law enforcement, because that's just something that especially if I take metformin, and believe me, it flushes you out. Woo! No. It's all again.
Yeah. Hey, but
That's another barrier. That's a barrier. You have to go
absolutely,
to the restaurant. And if you
absolutely.
don't, Maslow's hierarchy of needs, that's why Maslow's hierarchy of needs lists all of that. And having a place to live, having a place to use the restroom. When you're unhoused, believe me, there are some places that you have to go.
So important.
There are a lot of barriers with that, Yeah, that's all I got.
Rodney, thank you so much. I appreciate you sharing the vulnerability and sharing your experiences, because it's all real and we need to know this and be aware of this.
It's real. People need to understand that. The people who have health care issues, diabetes, high blood pressure, when you're unhoused, believe me, it's a challenge. Adversity, that's what I say. Adversity. Going through a lot of adversity.
Yeah, absolutely. Thank you so much. Lillian or Sarah, Birdie, did you want to talk a little bit about medication management? And then we'll switch to some success or facilitators.
I can speak on that a bit. So I think for what we see in our community a lot is health literacy. We have a great relationship with our local fire department, and we're working with like a system to implement with them for referrals. But they have a lot of people that are using EMS as like their first point of care if they don't have health insurance, which I think that's pretty universal in America, unfortunately. But a lot of it is they're told that they have diabetes by their primary care physician or whoever they're able to see, and then they're not given the resources, the food, the nutrition education necessary. So then they're having a diabetic episode and needing EMS, and then having to go to the emergency room. And it really just like comes back to like health literacy and providing opportunities for education for individuals to be able to have like stable blood sugars, and obviously food access. If you don't have access to the foods that are going to help maintain that, it's going to be a struggle for sure.
Thank you. Thank you, Sarah, so much for that. I appreciate your expertise and experience on that. And as we move into facilitators, if anybody wants to put it in the chat too, just anything else that they've experienced, if you are an individual with lived experience of homelessness, if you're a clinician, a provider, community health worker, please share with us in the chat. That would be really great. So let's move now to some facilitators. And since we have just about a few minutes left, I'm just going to group this. I want you guys to share any kind of things or innovative or creative ways that you've done or seen or heard of where it has helped somebody manage their diabetes outside of the four walls of the clinic. So across nutrition or diet, or physical activity, or medication management. So what have you seen work?
This is Lillian. So as a community health worker, we work with care teams, other providers. In the past, I've worked collaboratively with an occupational therapist to help a 19-year-old with diabetes try and manage her diabetes in shelter. Her mother had just passed away, so she was on her own. And so she and her OT created this chart with the time she was supposed to take her insulin and like a sticker for it and sort of like incentives and things to look forward to. And they were also helpful for me because I could always refer to her schedule and her chart. It was fun doing that with her and working collectively. We also have clients who meet with a nurse weekly to check in around diabetes management, and that seems to help folks that are staying close by the clinic. We also try to give some education when someone's coming in for something else. So like wound care is something that people come in for a lot, especially folks with diabetes. So we try as much as possible to to provide education wherever we can. And I think it's also important to talk about people who are not diagnosed with diabetes, but run a higher risk, and doing more proactive education and support to those folks. Yeah, that's it. Thank you.
Yeah, thank you. Sarah or Rodney? Yeah, go ahead, Sarah.
So we were running a veggie prescription program with our Backbones food pantry, and individuals each month would receive a bag of fresh and frozen produce and a lean protein, as well as some recipes and other nutrition education things. We were even, thanks to flexible funding with our grant, we're able to provide some kitchen gadgets. And this was about like a 2-year program, and we saw from the end a lot of people, their A1Cs decreased pretty significantly, which is fantastic. But it really, I mean, that was an individualized approach, and we were serving just shy of 30 people. But now we've been able to transition to have our food pantry have 1 week a month dedicated to fresh and frozen produce, and just like more diabetic friendly options as a whole, and even evolving to just having more healthy options every month. And we've been able to see just like a really great increase of the number of families receiving this. So on average, I think for that 1 week a month, and we've only started in January, we've seen 50 individuals, and even just like the household size, it went from being 1 to 2 that we were serving to now it's 3+. So that's been really great, just to see the impact of having access to that and how it can affect someone's diabetes.
That's wonderful. I love the idea of the prescription for veggie prescriptions. I think that's wonderful. I love that. And I think I've heard in the past other different kind of things too, just around using stickers to help. Some of you guys might have heard that on terms of like, how do you find the food? But one of the things, Sarah, just to go back to, is thinking about not only the different environments in which people are experiencing homelessness, but the situation, are you family homelessness? And so, right, so maybe you need to have those bigger amounts of bags of veggies and instead of individual size. So thank you. Rodney, did you have any facilitators that you experienced, or do you want to share anything that did work for you?
I would say the top box food program, because food is so high now, even the link card, because I don't know if anybody saw the USA Today. I told them they need to go back to giving people twice a month. Food is ridiculously high. People who work 9 to 5 are having trouble keeping food on the table, and they're getting a salary. The milk, the orange juice. So top box food is one of the programs. I think it was started by the Kennedy, that they bring out, I think every month, they deliver it to your door along with your SNAP benefits, because the SNAP benefits are not enough to get the food that you need if you need medication. And also the people who are working 9 to 5 need to have SNAP too, a basic need. But yeah, I think what the last 2 people with lived experience talked about, that's important to have the fruits and vegetables. But they bring it to your door. I think it's every month. Top box food, Google it. I think it was started by one of the Kennedys. So I use that program.
Okay, yeah, no, I've heard of Top Box before, so I'll have to look more into that. Thank you for that resource. We're gonna begin to close out. I just want to do a quick thank you to the panelists, and I will hand it over to Caitlin.
Sure, yeah. So thank you all. First, thank you again also to our panelists, Lillian, Sarah, and Rodney, for joining and sharing your experiences and insights. I think it's important to see just the commonalities, I think, amongst the challenges, but also then thinking about the unique considerations for individuals and families and housing or unstable housing type is what makes this work so challenging. But talking about the facilitators, I think, is also very promising to see how creative and how innovative people and systems are in working to address these different issues. So we are at the top of the hour. I'm going to wrap up. We are trying to launch a poll for our attendees, but I don't see it here to be able to launch. So if you have to jump off, please do. But I don't know if Elena or John, if you have it, to pull it up for folks to do. Otherwise, thank you so much, everybody, for joining us today. It's been a really great discussion.
I don't see the poll either. We can send it out to the listserv that participated today. All right. All right. I guess we can go ahead and end, Caitlin.